Hello everyone. The topic for today is iron deficiency anemia. Iron deficiency anemia, it is the most common cause of anemia worldwide as well as in India. It is absorbed from the proximal part of duodenum in ferrous form. Ferrous means Fe plus 3. It is stored in the form of ferritin. Transport form is transferrin and iron in the food is present in ferric form. Again, ferric form is Fe plus 3. We'll study the absorption of iron. Let me explain you with the help of a diagram. This is mouth, esophagus, stomach, small intestine. Let me make a big small intestine. Blood vessel and iron in ferric form. It is present in the food we eat, vegetarian, non-vegetarian, vegetables, everywhere iron is present. It goes in the mouth, esophagus and comes in the stomach. In stomach, we have acid called HCl. HCl converts Fe plus 3 to Fe plus 2, divalent form, that is Fe plus 2. This Fe plus 2 is transferred to the small intestine, that is the duodenum. In duodenum, we have duodenal cells called enterocytes. We have two transporters. The first transporter is DMT1, divalent metallion transporter 1, and as the name suggests, it transfers only the divalent ions, that is the Fe plus 2. Fe plus 2 enters the enterocyte. There's another transporter present on the other side of the cell, which is known as ferroportin. Ferroportin transfers this iron to the blood. But this iron is now transferred in the form of Fe plus 3. Ferroportin converts Fe plus 2 back to Fe plus 3. This iron doesn't go alone. It is transferred by a molecule known as transferrin. This one molecule of transferrin transports two iron molecules. This is the bone marrow. This transferrin, it goes to the bone marrow. It takes the required amount of iron with it. The remaining iron, it goes to the liver. That is, the excess iron is stored in liver. This is iron absorption. I just explained you. Again, look. This is food, iron present in food in ferric form. It is converted into ferrous form by HCl, the acid present in stomach. This is the transporter This is the transporter DMT. It transports Fe plus 2 to the enterocytes and further via transporter ferroportin, it goes in the blood. Here ferroportin converts ferrous back to ferric. It enters the blood. From blood it goes to the bone marrow with the help of transferrin, and the remaining excess of iron goes to the liver. There's one more molecule present known as hepcidin. Hepcidin is produced when there is excess iron in the body. It induces destruction of ferroportin. Hepcidin causes destruction of ferroportin. This is destroyed and iron is blocked here. Iron is blocked at the mucosa level. Therefore, hepcidin is inversely proportional to iron. When there is excess iron in the body, hepcidin is produced so that less iron is absorbed in the blood. Etiology: iron deficiency anemia is seen in cases when there is increased blood loss, increased requirement by the body, inadequate body intake. Wait, hold on. Something happened. Wait, something is happening. Wait for a second. Yes, we were here. Iron deficiency anemia, it is seen in case of increased blood loss, increased requirement of the body, inadequate dietary intake or decreased absorption. Increased body requirements, they are seen in case of infancy, in infant children, in case of pregnancy or in lactation. Blood loss can be seen in case of varices, ulcers, gastritis, leiomyoma, hemorrhoids, telangiectasia, uterine fibroids, ruptured aneurysm, intrahepatic bleeding, or amoebiasis. Now, the stages of iron deficiency anemia. Iron deficiency anemia can be classified into 3 stages: pre-latent phase, latent phase, and anemic phase. The first phase seen is pre-latent phase. Everything is seen normal in pre-latent phase except the serum ferritin. Serum ferritin levels are decreased in pre-latent phase. Untreated pre-latent phase leads to latent phase. The patient lands in latent phase. In latent phase, there is reduction in serum iron level, increase in total iron binding capacity, the MCV, MCH, RBC, and reticulocytes, everything is decreased, and the RDW, it is increased. Then comes the main form. If this stage is also untreated, the patient lands into anemia. Clinical features of anemia are iron deficiency anemia basically are the patient is fatigue all the time. The patient is dyspneic on exertion. Patient feels palpitations, pallor of skin, colichnia, alopecia, atrophic glossitis, Plummer-Wilson syndrome. There are unusual cravings known as pica, and some people also have restless leg syndrome. See, this is colichnia. This is the spooning of nails. You see, these are not normal nails. There is the spooning. There is curve like this in the nail. This is the spooning of nail, and this is atrophic glossitis. This is a normal tongue, and this is the atrophic tongue. You can see very well see the difference. This is shiny, normal. This is atrophic tongue. Now comes the lab investigations. Lab investigations for iron deficiency anemia. First, the blood investigations. We look for hemoglobin, RBC, retic, WBCs, platelets. Everything will be reduced except WBCs. They will remain unaffected. In bone marrow examination will be done. We look for the cellularity, erythropoiesis, and iron in bone marrow. Now, the question for today is, which stains iron in bone marrow? Comment your answers below in the comment box. The biochemistry tests are serum iron, serum ferritin, and total iron binding capacity. As we studied earlier, serum iron will decrease from the latent phase, and this is the most sensitive test as it is also decreased in the latent phase. Total iron binding capacity will increase. In case of bone marrow, there will be erythroid hyperplasia, nuclear distortion, chororrhexia, nuclear budding. There will be multinuclear fragmentation seen, and the normoblast will appear small and may have scanty cytoplasm with irregular ragged borders. This is the normal blood film. This is a neutrophil. These are normal RBCs. See, they have a central pallor, and these are normal RBCs. This is a blood film of a patient having mild iron deficiency anemia. The cells, normal RBCs, are comparatively smaller in size as compared to the normal PBC. These are, these are small platelets. These are RBCs, and we have few cells in the pencil shaped. This is the main PBF of severe iron deficiency anemia patient. This is a lymphocyte. We compare the size of RBC with the nucleus of a lymphocyte. So if we compare the size of RBCs, these are small RBCs. See, look at the size. These are small RBCs with increased central pallor. Small RBCs means it is microcytosis. The microcytosis of RBCs. Then we also have this pencil shaped cells, means there is poikilocytosis. That is, there is variation in the shape with central pallor. DDs of microcytic hypochromic anemia, which is iron deficiency anemia, anemia of chronic diseases, beta thal minor, and sideroblastic anemia. The most sensitive test was, as we studied earlier, is serum ferritin, which is usually low in iron deficiency anemia and normal to increased in anemia of chronic diseases. Management of iron deficiency anemia. The first treatment of choice is oral iron therapy. The patient is given oral iron therapy, and the major complication of oral iron therapy is gastritis. The patient suffers from gastritis. If this complication is seen in patient, the patient is given proton pump inhibitors along with oral iron. Oral iron. Side effects: complicating illness, failure of the patient to take prescribed medicine. In such cases, the patient usually don't respond to oral iron therapy. And the side effects, as I told earlier, are the GIT symptoms, heartburn, nausea, cramps. Iron therapy, it can be given either IM or IV, and it is parenteral iron therapy is only given if the patient is intolerant to oral iron or there is chronic blood loss. That's all for today. We'll meet for the next lecture soon. Thank you.